So Thursday morning, May 21st, and I managed to coordinate an interview with Dr. Richard Willy, who's at East Carolina University, and he's just up to amazing stuff in the running literature and really simplifying things for us. So thanks for agreeing to do this, Rich, and I just wanted to give you a chance to introduce yourself.
Thanks a lot, Chris. I certainly appreciate this opportunity. And yeah, as you mentioned, I'm at East Carolina University. I'm an assistant professor here, in our physical therapy department. We have a doctoral physical therapy program. I also, I work with a fantastic group of people here. Dr. John Wilson, Stacy Mirrodin, and Paul DeVita, and a couple others, Nick Murray being another one who's a motor control expert. So we have a nice research core here. We look at a lot of different injuries, but for me in particular, I really focus on running injuries.
So the manuscript that I first read by you that, was just very impressive was looking at mirror gait training. And
Right.
it was actually, you were the lead author, John Scholes, the late John Scholes, amazing person, brilliant thinker. I had a chance to be at University of Delaware when he was still teaching, as well as Irene McClay Davis. Can you go over or just sort of summarize the takeaways from that article? Because it was there are some very simple messages that I think translate into clinical practice. So.
Yeah, sure, absolutely. That was a really fun paper to work on as part of my dissertation. I should probably take a step back and say that one of the study that I did before that kind of helped set that paper up was, I'd been a clinician for 8 years and had been treating runners and of course lots of other stuff too. But I basically came to Irene Davis's lab, and one of the things that I really wanted to do was test some of the things out in our lab that I'd been doing clinically. And one of the main things was hip strengthening for things like patellofemoral pain, iliotibial band syndrome, the stuff that people have been doing for quite a while. And what we did was we looked at a bunch of female runners who had medial collapse mechanics. So these are individuals who tend to kind of come into a little bit more hip adduction, hip internal rotation, contralateral pelvic drop than what we consider to be the norm. And we put them through a very comprehensive strengthening program. It was about 6 weeks long and so forth, and looked at their running kinematics pre and post. And one of the things that we were really surprised, at least I was very surprised, was that their running mechanics didn't change whatsoever. So even though we put them through a very extensive hip strengthening program, something you still see people doing all the time now, it didn't really seem to make much difference as far as those kind of underlying kinematic risk factors that we typically associate with those types of injuries. So for me, that was a real eye opener for me. And the other thing we also looked at were single leg squat mechanics, and so those did change quite a bit. And in fact, they had considerably less hip adduction, pelvic drop, and also hip internal rotation after this exercise program. And I think, when you look back in hindsight, that really wasn't terribly surprising. And the main reason for that was that, we did single leg squats as part of their exercise program, and they had mirror feedback. So we taught them how to kind of monitor their lower extremity alignment and had them kind of work on, not letting themselves collapse in quite as much and so forth. So, I think in retrospect, I think that if we would have just taught them how to do this single leg squat and measure their kinematics afterward, I think we would have probably seen the same differences in their kinematics. So I think it kind of made me really kind of brought me around to the idea of thinking more about, movement skill rather than, some of these, the strength component, even though that's very important for a lot of people. I think just having the skill to move appropriately, is super important, and how we train people from a motor control and a motor learning standpoint certainly helps out. So the next step that we did was we moved on to doing a mirror gait retraining study where we took that example of using that full length mirror, doing the single leg squat, and try to apply it during running. And for this one, we used individuals who were symptomatic who had patellofemoral pain. And I kind of worked off some research that was done by one of my predecessors, Brian Noren, who did real-time kinematic feedback on hip adduction. And, very similar population. These were female runners who had patellofemoral pain, who had excessive hip adduction. And that was a great study, had excellent results. He did a 1-month follow-up, and these individuals seemed to maintain their reduction in their peak hip adduction after this intervention. But for me, one of the things, of course, I'm a clinician, and I like to always try to bring things back clinically. I don't know very many clinics that have a motion capture system. It's certainly no knock on Brian's work. It's just that, it's a very good proof of concept. And I kind of wanted to take it the next step further to see, okay, can we kind of dumb this down a little bit for somebody like me who's a clinician and make it something that's very, clinically practical. And so that's what we did. We put these runners through 8 sessions of mirror gait retraining. We gave them we gave them visual feedback, this full length mirror, and we gave them some verbal cueing on how to control the amount of medial collapse they're going into. So we looked at their overall function. We looked at their patellofemoral pain complaints. We also measured their mechanics during a single leg squat and also during a step down maneuver. And one of the things we found was that the mirror gait retraining seemed to reduce their medial collapse during all 3 of those tasks, which is a real big contrast to the strengthening study that we did earlier. So we found that it seems like, these, motor skills tend to trickle down to less demanding tasks. So I would consider a single leg squat to be less demanding than running. And also I would consider, step down maneuver to also be less demanding than running, but they don't seem to trickle up. And so that kind of started making me think about, all right, how should we retrain these different movement patterns and think about running more as a skill than an actual endurance task or more of a strength task and so forth. We looked at people 3 months after this study, and they had a very nice retention of all these changes in kinematics, but also a nice change in overall pain levels as well.
Yeah, and that was really interesting. I think that I was guilty of that during my younger years, where I'd try and basically build capacity and focus on a bunch of motor control drills, but try and work up to running. And that's what really struck a chord with me with your research. So, and I always think that perhaps if you can master something like this running, which is, a little bit faster, perhaps greater forces, you should be able to have better execution of these other tasks, such as, stair negotiation or single leg squat. So I thought that was just a very slick study. And, the interesting thing was, it seems like you were focusing predominantly on hip adduction. And I know some of Reed Ferber's work had looked at hip adduction as well as femoral internal rotation. But between Brian Noren's work and your work, it seems like hip adduction is the critical piece. What was the cueing that you were using during that study so clinicians may be able to adopt it?
Yeah, so what we did, the cueing that I gave them, I told them to increase the distance between your knees and get your kneecaps pointing straight ahead. So with the increased distance between your knees, with the targeting hip adduction, getting your kneecaps pointing straight ahead to be more focused on hip internal rotation. Even though we gave them cueing on that, we didn't see any change in hip internal rotation. And, I think there are lots of different reasons for that. First of all, when we were looking to see who was going to qualify, we weren't looking at people who had excessive hip internal rotation. We were looking for people who had excessive hip adduction. And so maybe these people didn't quite have the potential to change that. So if you don't have really high levels of hip internal rotation, it might be a little bit more difficult for you to change that. The other reason too, and I think this is something that's really important for people who are reading biomechanical research, particularly with something that's a little bit more dynamic like running or jumping, is that the movement, the measurement error associated with the transverse plane hip internal rotation is very high. And so for us, so that signal to noise ratio, there's a lot of noise associated with transverse plane measurements. And that's primarily because there's a lot of soft tissue movement. Things are kind of jiggling around a lot more so than in that frontal plane, and certainly the sagittal plane. So hip flexion and knee flexion, those things, we tend to measure those very well. And for repeated measures designs, we can detect very small changes for sagittal plane. But for the transverse plane, those changes have to be extremely large for us to be able to find them. So I think that's the other reason why we haven't found that. I know other labs have had some better success with that, and maybe they're doing something that we don't do. But for me, I always kind of tend to focus on something that's a little bit easier to measure, something that I can visually see as well. And I think the hip adduction, you can see that a lot better, even just doing a clinical gait analysis. And that's the other reason why too I've always kind of focused in on that.
And you were allowing subjects to go at their preferred running speed in that study. You weren't trying to address cadence or step rate at all, correct?
No, that's super interesting too, because we didn't, and we tried to keep that cueing very, very straightforward, and we tried not to deviate from that at all. But one of the things that we did do, and we didn't publish this, but we went back after the fact and looked at, you know, how much like their step rate and their step length and so forth. And one of the things we found was that their step length decreased as a result of this intervention. And that kind of makes sense, because if you're activating your glutes, you know, a little bit more so, you're not going to be able to take such a large step length. You're going to have to swing phase. And so you're going to have to shorten up your stride a little bit. So it seemed like those two things kind of go hand in hand. When you look at increasing your overall gluteal activity, that's going to reduce your step length. And it goes the other way too. If you look at some of the work out of Brian Heiderscheid's lab, if you reduce your step length, your gluteal activity also goes up too. So there seems to be this real important relationship between step length and gluteal activity and how much hip abduction you're going into.
So clinically, what does this look like? So say if you have a middle-aged female runner who presents with patellofemoral pain to your facility, what would a treatment session look like? So you take them through the evaluation, you may document certain inflexibilities or weaknesses in the lower extremity. Are you jumping right into the mirror gait retraining, or are you still giving exercises an adjunct to some of the motor control and skill acquisition training that you do on the treadmill?
Yeah, that's a great question. Well, yeah, certainly when we're doing research, we have to be a little bit different than the way we would practice clinically. And because we're trying to control things and work on that internal and external validity a little bit, or the internal validity, certainly. Clinically, I don't treat that way necessarily. I mean, as far as just going straight into gait retraining, we know that when you change somebody's gait, that you're going to increase the load somewhere else. So you can decrease it, say, you know, at the patellofemoral joint, or the tibia, or what have you. So in this case, we know that gluteal activity goes up quite a bit. So we would expect that the demand on the glutes would also go up during running. And so for me, I'm going to do a lot of things up front to try to get this person ready to do gait retraining. And so, you know, part of that's going to, of course, be a lot of gluteal strengthening, you know, whether it be open chain, and then I would eventually progress to closed chain. Also on top of that, you know, I'll probably do like a return to running program. So like some sort of interval, you know, walk run program to kind of build up their tissue tolerance as well. We also know that patellofemoral pain responds very well with quadricep strengthening. So I'm going to probably have a large quadricep strengthening component in there first. So for me, typically I'd start off with those things. And of course, it all depends on what I'm seeing clinically. And this I'm kind of giving, you know, focusing on a generic patient who has this medial collapse mechanic and has patellofemoral pain and quadricep weakness and you know, so forth. Then from there, I'll probably start to introduce the mirror gait retraining and go from there. At that point, you know, we're looking at, I can see in that paper, we used 8 sessions of gait retraining. We started to reduce that quite a bit. I think we can get it down to about 4 sessions of gait retraining. You know, and I think that we have to do that. We have to consider, you know, shortening things up a little bit, just because some of the, I guess, the fiscal pressures or the, you know, the insurance issues that we're all running into with, you know, treating patients who have patellofemoral or just any sort of thing in physical therapy.
So in terms of training the glutes, you know, that's obviously a hot topic right now. And, you know, when you look at some of the classic biomechanics papers and, you know, some of the other research, it seems like the glute max is active in anticipation of contact. And, you know, obviously Brian showed that, you know, some of the forces and activation patterns change when you start manipulating cadence. What do you think is important for clinicians to understand? So in terms of glute function is a function of where in the gait cycle it's hitting. So what would be the primary reason that you would tell somebody they need to train their glutes?
Well, you know, the glutes, the glute max and glute medius, those are the primary muscles that resist, or that, you know, extend the hip, externally rotate, and also adduct or abduct. And so, you know, for me, you know, the strengthening comes in where, you know, I don't want this person to get gluteal tendinopathy, for instance, you know, once we start doing some sort of gait retrain. So certainly it's something that's a bit of a concern. But I also want to make sure that people understand, or patients understand, that, look, these are very important exercises for you to be doing. They're going to hopefully somewhat injury-proof you when you're moving on to doing some sort of change in your gait. But at the same time, I also don't want to overpromise. And I want to also say, look, it's important for you to be doing this, and it's really, you know, and so forth. But what we need to do now is we need to incorporate that into your running. And if you don't do that, you're asking 2 hugely separate skills or tasks to, you know, affect one another. And that's just not going to happen. And, if you go back and you take a look at some of the basic science literature, and they look at, movement training versus like skill training versus strengthening, it makes sense when you look at what happens from a cortical reorganization standpoint. Strengthening doesn't really seem to result in any sort of cortical reorganization. And certainly it helps from a cross-sectional area standpoint, force generation, torque generation, and so forth. But skill training does. Skill training changes this cortical representation and allows you to, activate or control these motions a little bit better. And so if you're just doing strengthening, those things, cortical reorganization typically isn't going to happen. But I also tell them too that strengthening plus skill reorganization doesn't seem to have any enhanced benefits over just doing the skill reorganization or skill retraining. So the strengthening is important mostly from an injury prevention standpoint. And then you got to go into the skill training. So those are two separate phases from a rehabilitation standpoint. So I think it's really important to kind of emphasize both of those. And for me, I work with clinicians quite a bit, and as I know you do, one of the things that I see that clinicians do really well, they do the therapeutic exercise part really well. They're awesome at coming up with really great, interesting, very elaborate strengthening programs and so forth. And then the gait retraining part, I think, tends to maybe get a little bit of lip service, and I don't think that that's on purpose. I think that it's just, I think that needs to be viewed as a separate segment and not something to do maybe on the last day when somebody's getting ready to be discharged or one of the last days. I think it needs to be, okay, now we need to really focus in on that because these are the underlying mechanics that we feel are causing these injuries. And if you don't want to get re-injured, you need to change the way you're moving and try to sell it to the patient. And I think that part's super important as well, is to get that buy-in. And that's also another really hard thing to do is, okay, how are we going to get the buy-in from patients and explain this to them in a way that they can understand and that they're going to have buy-in, and because it's not an easy thing to do. It's very difficult at first. And I'm sure you've maybe tried some of these things. I know you do a lot of stuff with cadence, and even that's hard. I mean, I think that's hard for some people in the first couple of days that they're doing it. So.
Yeah, and I find that, cadence can be helpful. You have to give this in small bouts initially. I mean, I'll start with 30-second bouts. Mm-hmm. My patients always will say I call it sensory training. But I always tell the runners that I work with, I mean, if you think of golfers, I mean, they go to the range, let's say 3 or 4 days a week. They're playing the course perhaps 2 or 3 days a week. And runners are just always going to play the course. They're never going to practice running as a skill. So do you focus on anything from an auditory standpoint in terms of contact, or is it more looking at different anatomical landmarks or regions and trying to control with the mirror gait training?
Well, let's see. I guess it all depends. If I think that somebody has something wrong from a high impact standpoint, of course we have a great lab here. I have an instrument treadmill, so I can measure impact forces. So it's really easy for me to tell. I get impact force measurements on everybody who comes in. So it's very easy for me to see if somebody has high impact forces. If that's the case, then we'll do some sort of retraining from an auditory sound, like, trying to lessen the sound of their footfalls or something like that. But, we also do a lot of stuff with cadence, and that's kind of where I've been focusing a lot of my energies lately. And so forth. And we can talk about that a little bit more here in a minute, but just to kind of take a step back as far as the way that I'm doing the cueing, I've kind of changed the way that we're doing that with the mirror gait retraining. First of all, one of the things that we found is that clinically, a lot of treadmills have this really large console in the front of the treadmill, and Woodway, in particular, is this giant one, and you really can't even see your legs if you have a mirror set up in front. So we've started using a webcam to try to give feedback with a large screen in front of the treadmill. So we've been doing that. We've also been working on a little bit different cueing with our runners too, and we're starting to look at this from an experimental standpoint. So rather than telling them this internal focus of getting them to manipulate their body part or getting their kneecaps to point straight ahead, what we've been doing is been putting markers in the outside part of their knee and asking them to move the markers. So just try to readjust those markers, move those markers out, and we seem to be getting much better success with that. And that's that external focus of manipulating an object rather than manipulating your body. And it seems that like all the motor learning literature seems to be much more supportive of doing that during these retraining tasks. And the reducing your sounds when you're running, your footfall sounds, is also an external focus, because you're changing something in your environment rather than saying, okay, I want you to land with a more flexed knee or something along those lines, where when you do that, it's much more difficult. You're really constraining a runner to a very, very specific kinematic pattern, and that can make it much more difficult for that runner to learn that new task.
Yeah, and that makes a lot of sense. One of the things that's been interesting is if I do have someone that's overstriking, obviously, dealing with higher impact forces than I would expect, they seem to adopt what I call a full-footed stride when I try and get them to quiet down the sound of their foot contact. And it's obvious it's the heel strike, but it's sort of a full-footed stride. And have you seen that at all? If you were to tell someone to sort of just quiet down their feet, do you see them adopting any specific pattern?
Yeah, so we've been looking at that a little bit. We're not really giving feedback on the auditory sound in the study that we're doing, but we are kind of looking at we're giving feedback on loading rate. So that's how quickly you're loading your lower extremities, your impact forces.
Sure.
And we're not done with that study, but one of the things that we kind of see a lot, and I've seen this clinically too, is that runners tend to kind of almost Groucho run. If that makes sense, run like Groucho Marx, and they tend to kind of lower themselves down a little bit and tend to really rock over that foot a little bit, and I'm not so sure that that's a really good pattern for everybody to use. And I'm sure it's lowering their impact forces considerably. They get drastic reductions in their overall impact forces. But when you do that, you're also increasing the load on your anterior tib and a couple other structures as well. So I kind of worry sometimes. I don't know. I would say we don't really know what are the best cues for changing these things. And for me, a lot of times I come back to cadence, and I really kind of like that one, just because it seems to really kind of fix a lot of different things. It lowers your impact forces, lowers your work at your knee, lowers the work at your hip. It also changes your hip adduction, although not quite as much as the mirror gait retraining does. And when you do that, it tends to allow somebody to kind of come up with their own kinematic pattern, and they don't seem to end up running like Groucho Marx or something like that. So, but for some people, they still need that. Okay, I need you to listen to how hard you're hitting the ground, and sometimes that's a nice extra cue to kind of help them, get it for whatever change you're trying to get them to do.
So you had a study that just came out. Was it in the Scandinavian Journal?
Yeah, Scandinavian Journal of Medicine and Science and Sport. It's a bit of a mouthful, but yeah. We just.
And can you go over that research a little bit? So you were sort of looking at step rate, and you had selected, I think, an increase of 7.5%, which sort of seems like it split the difference between what Brian showed. Mm-hmm. Can you just discuss that research a bit?
Yeah, absolutely. So what we did, we screened, I think, 86 runners. We had them come in. We did a very quick screening to see if they had high impact forces. The reason why we did that is we don't really want to try to lower someone's impact forces if they don't have high impact forces. And so we were looking at people who had very high loading rates. So we came up with 30 runners. We then did a randomized control trial. So we, randomly allocated them to either a control group or a treatment group. And what we did was we gave them all Garmin FR70, Forerunner 70. It's a very simple Garmin unit. Uses a foot pod to give you real-time feedback on step rate. And I like that. I like it a lot because you can run outside, you can run on a treadmill. You don't need a GPS signal to get what you need out of it. So we gave them all these Garmins. We asked them to increase their step rate by 7.5%. And the reason why we chose 7.5% is, again, just like you said, it kind of split the difference between the two. But clinically, it seems like 5% is good. It doesn't seem like it's quite enough, but 10% seems to be really difficult for a lot of runners. So the 7.5% seemed to be something that made the most sense to me. So I kind of went with that. And so we asked everybody to increase their step rate by 7.5%. The Garmin gives you real-time feedback on that, which is really nice. I know, back when we first did this, let's see, we started that study in 2012. There weren't really a whole lot of units that were doing that, but now it looks like a lot of units are giving you real-time feedback on step rate, which is really nice. I'm really excited to see that because that means that people can use this, this study's protocol in their clinical practice. So we had them do that. We had them do it over 8 sessions. versus the mirror gait retraining study, we did not have them come into the lab for these sessions. We had them go out. We didn't tell them to change anything about their running program except this. We said, I just want you to just change the number of steps you're taking per minute. And we gave them a phased feedback schedule so that they didn't get feedback continuously. So they were asked to kind of look at their watch, let's see, on runs 1, 2, and 3, and 5 and 7. And then the opposite runs from that, like I said, would be 4, 6, and 8. We asked them not to look at their step rate when they're running. And what we found, this is after 8 sessions of gait retraining, they did it out, they run around, people ran on a treadmill, ran, on a sidewalk, wherever, just their normal running routine. We had them come back in and we looked at their step rate. We didn't give them feedback anymore on that. And they had really nice reductions in their overall step rate. They also had nice reductions in their impact forces. And those impact forces, of course, are associated with tibial stress fractures. There's some evidence that it might be associated with patellofemoral pain. They also reduced their knee joint work considerably as well. And also their hip adduction. Hip adduction reduced by about 3 degrees, which lines up pretty closely with Brian's work as well. So I think Brian's finding a reduction of about 3 degrees in hip adduction. Doesn't sound like a lot, but it is when you're looking at, people that only have, 15 to 17 degrees of total hip adduction. So you're reducing that considerably. So let's see, after that, we had them come back a month later after they got done with the retraining phase, and not everybody, but almost everybody had a really nice retention of this new step rate pattern. So we were really pleased with that. I think from a proof of concept standpoint, it shows that you can do gait retraining. You don't have to have people come into your clinic to do it. So, and again, I think that kind of makes sense when you look at the current, state of our practice as far as from an insurance standpoint. Then you can do the gait retraining at the end of your physical therapy. All right. So maybe you get through physical therapy, you have somebody who has a tibial stress fracture, you're rehabbing them, you're putting them through like a walk-run program. You get them set up with a Garmin unit. I think with the Garmin, I think it's $150. I mean, that's a bargain. I mean, that's a total bargain if you can reduce their overall impact forces. So you get them set up with this and you put them on this program or something similar to that, and you can expect to see nice reductions in the overall impact forces and work done at the knee and the amount of hip adduction. And all those things we associate with a variety of different injuries, the lower extremity tibial stress fractures, iliotibial band syndrome, patellofemoral pain, and so forth. So so we were really pleased with that. Of course, that was on a non-symptomatic population. So these were people who were uninjured. Now, a lot of them had injuries in the past, tibial stress fractures being primarily the primary one. But I think the next step then would be then to apply this to some sort of injured population, for sure.
Well, that sounds great. Yeah, I thought that was, all your research is awesome, but I thought that was a pretty slick study.
Oh, thanks.
So switching gears a little bit, ankle dorsiflexion is the other thing that's getting a lot of a lot of attention in the literature. There's a group out of Israel that's doing a lot of interesting work. I want to say the pronunciation's Robin in colleagues. So they're looking at it a lot in patients with patellofemoral pain as well as in military recruits. How are you? What's your perspective as a clinician on ankle dorsiflexion, and how do you sort of evaluate it and address it, whether it's through exercise, stretching, joint mobilizations? Could you delve into that a bit?
Yeah, absolutely. So the foot and ankle are a little bit tough when it comes to gait retraining. And I say that because, like, for instance, if you change your step rate, that doesn't really change the load down at your ankle. It doesn't change your plantar flexor load or anything like that. So, and I don't want, even though I do research in gait retraining, of course, clinically, I do a lot of different things. And when it comes to ankle dorsiflexion, of course, I measure that just like everybody else. I use a weight bearing technique where I have people lean in toward the wall and look at that tibial inclination when they're doing that. I also measure them on the table. Knee straight, knee bent, put them in subtalar neutral, at least where I'm approximating it, and then measuring it that way. So treatment-wise, I do a combination of stretching. I like to strengthen into dorsiflexion. And then I also do a lot of joint mobilizations. So I really like the Mulligan technique with the belt, and really work on doing a nice closed chain glide to try to improve that. As far as from a biomechanical standpoint, I think when somebody has reduced ankle dorsiflexion, I think it can do a couple different things. I think, and I'm sure you probably see these too, but people tend to toe out a little bit more, so they increase their knee external rotation, and I think that has some real consequences up the chain. increases that knee external rotation, so they're going to get more lateral tracking of their patellofemoral joint. It may also increase some torsional loads on your tibia, and that torsional load is something that may increase your risk of tibial stress fracture as well. And what else? And it may also increase your load on your plantar fascia. So I think those are things that I'm also always trying to keep into consideration. Oh, also Achilles tendon, because that twisting of that Achilles tendon seems to increase your risk of Achilles tendinopathy. And I think there was a really nice systematic review that came out last year that was kind of showing that pretty clearly.
That was was Blaze Williams doing some work with that when he was at Delaware? I think that he has an article published along those lines, looking at sort of the rotational forces that the Achilles is exposed to. That's something I see a lot clinically. So it's sort of comforting to hear we're, I think, focusing on the same things with runners coming in. I started sort of I accidentally stumbled upon this test, which I'll send you a link to it, but involves essentially stabilizing the midfoot with the patient in a hook-lying position and then having them abduct and externally rotate when they're on the table. And this is something that I started studying a little bit when I was at the Nicholas Institute before I left. We don't know what we're measuring, but this is something that seems to really correlate with dorsiflexion range of motion. So I'll send this to you, and it'd be fun to have you play with the assessment and just see what you're picking up clinically. So again, with ankle dorsiflexion, what do you think is important from a heel to toe differential standpoint? I mean, how does that enter the equation when you go to make shoe recommendations or running footwear recommendations?
Yeah, that's one of those it all depends kind of questions. I think that when I see somebody who has a really tight heel cord or patellocrural joint or what have you, I don't know. For me, I think like a higher rise shoe or higher drop shoe is going to be the way to go. Just because, I mean, why change that? Why do I want to upset things? And so for me, I don't see a big problem with that much of a heel to toe drop for somebody like that. Somebody has normal range of motion, I may be more inclined to say, maybe this is a shoe that may be worth trying out. The other extreme would be one of the groups that we're starting to do a lot of research with are people who are recovering from an Achilles tendon rupture. And this is a project that I'm doing with Karin Silbernagel, who's now at University of Delaware. She's from Sweden. And one of the things with people and these are active people, they've had this Achilles tendon rupture, and one of the problems they have is that their tendon heals elongated. So they've got this really long tendon, which is the exact opposite of what we typically see with most runners. And most people who get these Achilles tendon ruptures, these are people who want to get back to being active. Maybe they got it during playing soccer or something like that. And maybe they're being smart and they're saying like, okay, I don't want to go back to soccer, but I still want to stay active and I want to run. Those are people that I'm going to be more inclined to put into a flatter shoe. And because it's going to elongate that tendon or stretch that tendon or load it a little bit more so they can push off a little bit more efficiently. So I guess it kind of all depends. So I guess, tight people, I'm not super concerned about. I kind of want to keep them away from the flatter shoes. People who are hyper flexible, these Achilles tendon ruptures, those are people that I maybe might steer in that direction.
So there was some really interesting research that Mike Mullaney was doing when I was at NSMAT. And he basically, he wrote it up for American Journal of Sports Medicine, but basically showed after Achilles tendon repair that people developed this end range plantar flexion weakness. It was just really clean data. And we stopped stretching people for at least the first 12 weeks. We were doing sort of active mobilization consistent with the flexor tendon repair literature in the hand. And we seem to be able to safeguard against this stretch out. And it's something, it's like, when you're in school, you're taught to stretch, and I thought that was something that really had an impact on the way I rehab people. Have you come across that manuscript?
I haven't seen that one, but I've, as far as most of this Achilles tendon rupture literature is coming out lately, I mean, it's all saying the same thing. It's all saying, don't stretch these people. These people you need to go through active motion. You want to be really careful about loading these people, particularly in the early stages of healing, up into dorsiflexion, and because you want this tendon to heal, maybe not necessarily tight, but you don't want to elongate it. And clinically, that's one of the things that, we end up seeing a lot of people that have gone through rehab where they've done a lot of stretching, or maybe they've even done some treadmill walking on an incline or something like that. And I would say that's probably not necessarily a very good idea, because you're basically preventing this person from having that I guess, optimal length tension relationship when you're looking at the musculotendinous unit for the gastroc and the soleus. And then as a result, if you're not getting your power from your plantar flexors, it has to come from somewhere else. And one of the places that we're seeing a lot of excess load in these individuals is up at the patellofemoral joint. So we tend to get a little bit more patellofemoral joint stress, more tibial femoral contact force. And I wonder what we're doing with, with these people. I think from a long-term standpoint, 10, 15 years down the line, if we're increasing the risk of tibial femoral osteoarthritis or patellofemoral osteoarthritis, if they've got these really long tendons and so forth. So yeah, I think, the main key is, if you look at the hand literature for tendon repairs, the modified Duran protocol, there's a reason why there's the modified part. The earlier one had very little motion in the early stages after a flexor tendon repair. And now the modified Duran protocol, which has been out for a while now, has a lot of early active motion and also passive motion as well too. And I think when you look at Achilles tendon ruptures, I think that's one of the things that we're finding as well, and others certainly are finding, is this early motion. And what I mean by early, I mean like is in the 3rd week. And it's early protected range of motion, for sure. And I think if you do that, as you mentioned, I think you can really reduce the risk of having this elongated Achilles tendon.
In the clinical tests that we were using at NISMAT were basically to have people toe walk, and what you would see is on the side that they had the repair, if it was stretched out, their heel would start to drop. They couldn't maintain that end range position. And along those same lines, if you put them on a decline slant board and had them do a single leg calf raise, if they had stretch out, they weren't able to do that. And again, most people who are sort of relatively sedentary may not be aware of this weakness, but folks who are gymnasts, basketball players, participating in sports that require them to go up on their toes, they would definitely know that something was off. So, it's interesting. I'm glad you're sort of seeing a similar pattern there. So, in terms of manual therapy, how much manual therapy are you using when you're treating clinically?
Well, I think certainly down at the foot and ankle, that's where I do most of my manual therapy. And so for that, whether it be first MTP restrictions, I'll do a lot of manual therapy there. Talocrural joint, particularly up at the hip. I treat a lot of people who have FAI. And one of the things that I do a lot of lateral glides and posterior glides and so forth with those individuals, and also anterior glides as well. One of the things I do with that group too, I also teach them how to do self-mobilizations with a belt. And so I'm anchored into a door and get them a mobilization belt and spend a lot of time doing that. So, one of the things though that I always try to keep in mind is that, I think that mobilizations, and I'm not a big, my background's not in soft tissue mechanics by any means, but, I think our mobilizations that we do, I don't think that they always necessarily do what we think that they do. And I think that Mike Raymond at Duke has really been talking about this a lot up at the hip. And it seems to really result in really nice pain reduction for a lot of people. And I don't know if it's necessarily changing the capsular tightness or some of the things that we would like to think that it does. So I try to keep that stuff in mind, but I still do a lot of manual therapy with those folks. I still do some patellar mobilizations, particularly my post-op patients. I do a lot of that for sure, definitely. Patellofemoral pain, we have some individuals as well, but basically at opposite ends, the foot and ankle and up at the hip. Do a lot. I
would say, yeah, I'm sort of focusing on the same areas. Do you think that there's a sort of a critical threshold value in terms of range at the first MTP joint? People always ask me this, and I know Jay DeSherry has cited 30, 35 degrees in some of his work. But do you think there is a critical value with first MTP extension as well as ankle dorsiflexion with the knee flexed?
Yeah, I guess it all depends on how you're measuring it. If you measure it, unweighted or non-weight bearing, you can get quite a bit more dorsiflexion, and that's typically how I measure. I measure it in prone. The person flex their knee up to 90, and then I measure it there. And for me, I'm looking for about 70 degrees of first MTP extension, which is quite a bit. This is for running. For running and for walking, you don't need as much. You need more around 40 degrees. Now, I will say when you measure that weight bearing, that value drops quite a bit, probably down to around the value that you're kicking around as far as in Jay DeSherry. This is what, 30, 35 degrees. So I guess it all depends on how you're measuring that. I don't know, how's that, does that sound about what you see too, or?
Yeah, I would say so. I mean, I'll measure it sort of at terminal stance, and
Okay.
a lot of times I'll just passively elevate the joint. So yeah, I would say that we're collecting measurements in a pretty darn similar manner, which is good to hear. There's a study that just came out, well, maybe a year or two ago, and it showed that the reliability was not great with that measurement. But again, it's something I still look at. And, you know, I know in my case, I have about 75 degrees actively of first MTP extension. So, but yeah, you start to see a lot of compensatory motions if people don't have clean motion there, as well as at the ankle joint. I feel like that starts to really dump into things upstream. And you know, if there's a case made for regional interdependence, it's largely driven by those regions. So
yeah, I absolutely agree. And I don't know, it's not too often I see somebody who has problems that has too much motion there. I mean, of course, there are going to be extremes, but more often than not, I see people that tend to be very restricted there. And then, as you mentioned, it causes some compensatory motions, towing out, and that causes some problems up the chain as well. And you know, you basically, when you toe out, you've got this first MTP restriction, you're getting this lateral glide on that first MTP joint, you know, every single step that you take. And so, you know, it's not surprising we start seeing hallux valgus in those individuals. There seems to be this real, very close relationship between, you know, first MTP restriction from a dorsiflexion standpoint and also hallux valgus. So yeah, I think you're right. I think we absolutely are looking at things the same when it comes down to the foot and ankle for sure. So you mentioned dorsiflexion a minute ago. Like what kind of motion measurements am I looking for? You know, I know with our motion capture, what we see as far as peak ankle dorsiflexion and mid stance, it ends up being about 15 to 20 degrees of peak ankle dorsiflexion that we see kinematically. But I want to be really cautious with that too, and that, you know, it's easy to assume. So we model the foot as just a single segment. And obviously it's much more complicated than that. We got the midfoot, the forefoot, and all that stuff. And you can get dorsiflexion from any of those places. So even though we're seeing 15 to 20 degrees, you know, I don't necessarily say that, you know, somebody has to have 20 degrees of ankle dorsiflexion to be a good runner. And in fact, I see a lot of runners that get to neutral, to get to zero. And so I don't know, is that, what do you see?
Yeah, well, I guess just in discussing this, I'm amazed with people's ability to adapt. And it's, if they don't have, I mean, I typically would say that I see roughly with healthy runners about 20 degrees of ankle dorsiflexion with the knee flexed, measured in prone manner, which you described. And I find that if people don't have that, they're going to start to adopt a little bit of a toe out pattern. They're going to go to the midfoot or the subtalar region to try and buy additional motion. And that's where I see a lot of problems start to arise if things start to become symptomatic. So I think, again, it's just sort of figuring out who's in front of you, what their impairments are, and how they run. So I get very concerned when people come in who have a history of ankle sprains, because most of the time I know that they haven't completely rehabbed it. And that's when I see a lot of compensatory motions start to take place. So
yeah, I mean, I hate using like thresholds for when I start getting concerned with somebody, but for me, I like to see at least 10 degrees of, you know, of ankle dorsiflexion with your knee flexed, at least 10 and preferably 15. So I think again, we're kind of in the same range there. But yeah, I think you're right. It really causes some real issues up the chain if you're lacking that, if you're also lacking that first MTP joint extension as well.
So, well, hey, look, we covered a lot of ground here, and I think this is going to be a tremendous resource for viewers. So we'll wrap things up here. I can't thank you enough, Rich, and keep up the great work. It's had a huge impact on my physical therapy work, and I think it's very helpful hearing from you, because you did spend a lot of time in a clinic, and you're sort of, I see these ideas translating into your research. So if you're ever out in Seattle, please reach out. And again, thank you so much for your time this morning.
Oh, it's been fantastic. I've really enjoyed it. So thanks again. I really appreciate it.
Of course. So this is going to be posting on social media. I'll put it up on my website at some point in the next few days, and I'll make sure to send you a link.
Yeah, that sounds great. Thank you so much.
Of course. Thanks, Rich.
Thank you.